Good evening. Is that on? I don't think it's projecting. Good evening and welcome. My name is Deborah Parker. I'm the Dean for the College of Pharmacy at the University of Findlay. I'd like to welcome all of you here. It's a pleasure to see all of you. We have students and faculty from the University of Toledo, from Ohio Northern University, and of course from the University of Findlay, and we welcome all of you. We have leaders in our community, we have faculty, we have representative from the political world. We have John Cross. John, would you mind raising your hand? John is from the Kenton area, and he is running for state representative, 83rd District, so we appreciate him being here and listening in to hear what is important to the community of pharmacy and to our patients in Ohio. That said, I will not delay things any longer. I'm going to turn things over to Dr. Ryan Schneider. Dr. Schneider is a faculty member here at the University of Findlay, and he is also the current president of the Ohio Pharmacists Association. He'll be kicking things off and emceeing a little bit later when we move to panel session. Dr. Schneider?
Thank you, Dean Parker, and welcome to all of our guests here this evening. It is my pleasure to introduce the topic tonight of a 2018 Pharmacy Legislative Update, where we're going to have a nice discussion this evening on pharmacists as providers. And so behind me you can see the list of presenters that we have available tonight that are going to speak, and we have several different pharmacists from various practice settings. We have a patient advocate that will be joining us. And we have the Executive Director of the Ohio Pharmacists Association, and Ernie Boyd, who will also be with us speaking this evening. And then upon completion of all of the presenters, we will have a question and answer session as a panel. So if you're thinking about the questions that you would like to ask throughout the evening, please do so, and we'll have a nice engaging discussion at that point in time. So I have the easiest job of the evening because I just get to introduce an overview, a 30,000-foot view, if you will, of the topic of pharmacists as providers. And then I'll turn it over to my colleagues that will get down into the nitty-gritty of what it means to be a provider in various practice settings. And so here's a list of frequently asked questions, if you will, that often come up when we talk about provider status. You might just ask, what is a provider? What does that mean? Does provider status equal prescribing? And then what efforts are being made to allow pharmacists to be classified as providers? And lastly, and this one comes up oftentimes, is this a federal or a state issue or both? And so I just wanted to spend a couple minutes just addressing these questions because I think it's important as you go throughout the day or the evening and you hear from the various pharmacists that are going to speak to understand and make sure that you're all on the same page. What is a provider? Okay, what is a provider? And so to really understand that, we need to think about the paradigm of pharmacy. And oftentimes we as pharmacists are thought of as dispensers of drugs, medications, right? And so I think that is still the case, and the pharmacists dispensing medications is still a very important part of pharmacy. But I think what you're going to hear tonight from various other speakers is that pharmacists are also dispensing services, if you will. That's a nice way to think about it. That they are providing patient care, direct patient care. They're working collaboratively with other healthcare providers, and they are not currently able to bill for cognitive services that they're providing to the patients. And so basically being a provider at the basic level is being able to bill for the services that are being rendered. All right, pharmacists currently have very limited ability to bill insurance companies for those services that they're providing. And so what we're seeking with legislation is to be able to bill at a level that doctors or nurse practitioners or other providers can bill for. And so that leads me to the next question, which is, does provider status equal prescribing? So oftentimes the two are confused, and what I would say is that they are not equal at all. By being classified as a provider, we're simply asking for that ability to bill for services rendered. Prescribing isn't part of the current legislation language that we would be seeking. And by many rights, pharmacists in certain practice settings via collaborative practice agreements already have some sort of prescriptive authority. We are not really looking to expand that with this type of legislation. And then the next question, what efforts are being made to allow pharmacists to be classified as providers? We really have multiple different avenues that are being pursued at both the federal and state level. At a federal level, you'll hear momentarily that we have legislation in both the House of Representatives and the United States Senate to address this. And we'll also talk about briefly a current Senate bill, Senate Bill 265, that's being taken on in Ohio. But beyond that, there are other ways besides legislation that we can address this issue, and we have a pilot program currently being done in the state of Ohio with an insurance company where they are credentialing pharmacists as providers without legislation to back that up. And that's okay, that can be done. So that's one way, it's just a slow way. And so one way that we think will hasten that will be to have legislation that is passed. The other way is an administrative perspective that can be taken, and that would be where we would work with Ohio Medicaid, for example, to try to be listed as being able to bill for services with them. So shown here is the current legislation, and just a high-level overview of what current legislative efforts are being undertaken in this area. We have two bills that are identical at the federal level. We have House of Representatives Bill 592 and Senate Bill 109, also known as the Pharmacy and Medically Underserved Areas Enhancement Act. And essentially what these bills would do, they would allow for pharmacists to be credentialed as providers and being able to bill for Medicare services. So, and keep that in mind. Medicare is who we're talking about at the federal level. At the state level, we currently have Ohio Senate Bill 265, and we'll talk a little bit more about that bill here in just a moment. But it was introduced and sponsored by Senator Matt Dolan. And this would basically change any place in the Ohio statute where providers are currently defined. It would add pharmacists to that list. So if it lists doctors and nurses, nurse practitioners, and so on and so forth, any place that those are listed as providers, it would add pharmacists to that list. And it would change the Ohio Revised Code to reflect that. So I'm going to focus my efforts at this point on Senate Bill 265 because we think that that's where some of our best efforts are, at least at this point in time for the remainder of this calendar year. And so what are the outcomes of Senate Bill 265? Well, what this would do is it would allow pharmacists to be eligible to be credentialed as providers for private insurance companies. All right, so remember at the federal level we were talking about Medicare. Here we're talking about private insurance companies. What's not listed here is Medicaid. Okay. Now it's important to keep in mind that whenever we're asking for provider status, that none of the provider status bills that are currently out there are mandates for payment. And I think that's a very important thing to keep in mind. If the law passes, it does not say you must pay pharmacists to render these services. Rather, it allows pharmacists to be able to enter into conversations with these various healthcare plans and work out arrangements for them to be able to bill for services. Okay? Ohio Senate Bill 265. What of the overall impact here? We're talking about a third of the patients in the state of Ohio we could be eligible to bill as a provider for them. Those that have private insurance. Okay, it does not impact Medicaid and it does not impact Medicare. So what's the status of the current legislation? At the federal level, all right, we have currently 53 co-sponsors of the Senate bill. And we have 293 co-sponsors of the House bill. All right, and if you do the math, that should tell you that there is a majority for both of those that are in favor or support of provider status. So what's the holdup? Well, currently, the Congressional Budget Office scoring of this bill is that it has a high cost associated with it. Now, you might ask yourself, why is that? There's several studies that are out there that are going to suggest that pharmacists provide a value, they're going to save the healthcare system dollars. Well, the Congressional Budget Office scoring of this does not take that into consideration. What it does is it looks at pharmacists as being another provider that could be billing the federal government. And so it looks at more providers, more money, more cost to the federal government. And so that's the current holdup and the climate in Washington at this point in time. As we flip to the state level, we look at the status of Senate Bill 265 and its next steps. Currently, this bill is in the Senate Insurance and Financial Institutions Committee. It has had 3 hearings to date and has only had minimal opposition. Currently, we are in the process of drafting a minor amendment to address the opposition testimony. And at that point in time, we anticipate a 4th hearing and then ultimately passage out of committee that would send the bill to the full Senate. And our hope is that that will happen sometime within the next month or so. We have elections coming up here in November. And at this point in time, most of the legislative action that will happen in the state will happen after that election, in that lame duck session between elections and when the new legislators take office. And so what our hope is and conversations are happening, especially with lobbyists for Ohio Pharmacists Association, is that we are kind of lining up our various ducks, if you will, to make sure that this becomes a priority piece of legislation as we get into November. And our hope is that ultimately we'll have a passage of a bill that will be sent on to the governor, but time will tell. So stay tuned for that. We do anticipate some of that legislative action. I think Ernie can talk about that a little bit later. And so the last thing that I would like to touch on this evening before turning it over to our next speaker is to start thinking about, in your minds, what would pharmacist provider status mean for pharmacy? All right, so we're talking about potentially opening up other avenues for payment for services that pharmacists are providing. What could that mean to future job opportunities? What would it mean to patients and the value of care that you're providing to them? So I don't have all of the answers, but I think you're going to hear some examples that might be some answers for you at this point in time. So with that, I am going to turn it over to our next speaker. It is my pleasure to introduce you to Dr. Susie Surowiec. Susie is an assistant professor of pharmacy practice here at the University of Findlay College of Pharmacy. She also practices as a clinical ambulatory care pharmacist at Blanchard Valley Medical Associates here in Findlay. So with that, I'll turn it over to you, Dr. Surowiec.
Hello, everyone. So thank you, Dr. Schneider, for that introduction. So I'm going to talk a little bit about my practice site before I get into the importance and the impact on patient care for Senate Bill 265. So I work at Blanchard Valley Medical Associates. That's a private practice here in Findlay. We have a gamut of specialties, as you'll see on the slide behind me. So cardiologists, internal medicine physicians, and you can see the list goes on, dermatologists, endocrinologists, et cetera. So a wide variety of specialties at the practice site. And then here are the kind of healthcare team, if you will, at BVMA. So you'll see on the slide we have 16 physicians. We have numerous physician assistants, nurse practitioners, pharmacists, including myself, nurses, lab techs, et cetera. Specifically for pharmacists, if you count, full-time equivalents for pharmacists, we have 2 full-time equivalents. So those 4 pharmacists make up 2 full-time positions. So it's a lot of part-time people coming in to manage our patients. So a little bit about the clinics that we run. So you'll see there all the clinics that the pharmacists are involved with, the biggest being anticoagulation, and then second would be our antiarrhythmic monitoring. So we're seeing patients with all of these different disease states, these different medications to take care of them, and these clinics are based on physician referrals. So physicians refer patients to us in our clinics, and then we see the patients on behalf of them, and we work under collaborative practice agreements with the physicians. Other duties besides our clinics that we're running, we answer a lot of drug information questions. So whether that's for the physician or the patient's family members, nurses, etc. Lots of questions throughout the day that come to us to field in between seeing these patients for a lot of these disease states. So it can make for a very busy day, as you might imagine. Other things we do, we analyze laboratory results, call patients with those results and explain, what these numbers mean to them. And then we also assess various problems, various concerns throughout the day, whether that's patients coming into the office or patients calling in with, questions, concerns, complaints, and then it would be up to us to triage to the appropriate provider. So, what is the importance of Ohio Senate Bill 265 to us in the general medicine world? So if we're thinking general medicine, well, there's several. Physician shortages are the biggest thing, or one of the biggest things right now. So physician shortages are expected to grow even worse in the coming years. So pharmacists can help fill this gap and serve as physician extenders, if you will. So physicians already are depending on pharmacists to complete these tasks, to do these services, to help see these patients and take care of them, simply because they do not have the time. Other things that ambulatory care pharmacists can do, or pharmacists in general, we can help in the area of chronic disease state management. So we can help with these chronic disease states and managing medications, helping to decrease overall costs, whether that is a medication cost or helping to prevent a hospital admission or readmission, helping to prevent side effects that could ultimately land someone in the emergency room or hospital, and just helping to manage these patients with these chronic disease states. As you are all aware, Ohio is currently in an opioid crisis or opioid epidemic, so patients and physicians can utilize us as pharmacists to help pharmacologically manage these patients. We can help recommend alternative therapy. We can help, taper doses of medications. It's all for the good of the patient. And then when the pharmacist is involved in the care of patients, and we can focus on medication education, adherence, preventing those adverse drug events, better health outcomes, can and will be achieved. And if any of you are familiar with Ohio's MTM story, that shows the value of pharmacists in Ohio, and it shows the positive influences we can make on improving patients' health, patients' lives, when a pharmacist is involved in their care. So other impacts when we're thinking about patient care, and I've mentioned some of these already, but just to reiterate, pharmacists can help decrease overall healthcare expenditures. That could be in the form of avoiding, like I said, hospitalizations, readmissions, detecting, resolving, and preventing any kind of medication errors or medication-related problems, and then overall improving the quality of life of our patient. So we as pharmacists continue to remain the most accessible healthcare professional to our patients. So the allowance of adequate reimbursement for these non-dispensing services by a pharmacist can increase patient reach. It will ultimately decrease the burden on physicians. It can improve access to care and just improve overall patient care and well-being when pharmacists are involved. So I'm going to talk for a few minutes about some challenges and sustainability in my current practice setting. So this is directly with what I'm experiencing right now at my practice site at Blanchard Valley Medical Associates. So the first thing is we have antiquated billing models that will not allow us to bill for the level of service that we as pharmacists can provide. So what that means, students, is that pharmacists are only allowed to bill the lowest level when it comes to a billing model. So that means the lowest level of reimbursement, no matter how complicated that patient is, no matter how complicated that medication regimen, the patient concerns, the patient disease states, it will always be that lowest level no matter how long it takes. So this then creates a snowball effect. So for pharmacists to break even with salary, that doesn't count costs of supplies, it doesn't count pharmacist benefits, taxes, overhead costs of the building that we're in. So just to break even with salary, we have to see 4 patients an hour for our physicians. So obviously this is a huge time constraint. It's going to impact patient care. I can think of countless times where I've said, we're here today to look at this medication or this disease state. I'll be happy to look into this for you at a later appointment, or let me refer you to the physician, or let you see a nurse practitioner, call a secretary, what have you, simply because there's not enough time in the day to deal with everything. On top of that, we have an increase in our elderly patient population, as you, I'm sure, are all aware. So what that means to us is we're getting more patient referrals from our physicians because we have more elderly patients with more problems, more complex medication regimens, and there's just not enough time slots in the day, even if we're seeing a patient every 10 to 15 minutes. So if we're overbooking patients, that's really impacting our patient care and allowing us less time to see patients. So I realize reimbursement does not directly affect this. However, allowing us to bill for a higher level of service would allow physicians to feel more comfortable to hire more pharmacists in this setting that can see patients and do this clinical work. So what I fear is that this could cause a burnout sensation for pharmacists that are in this setting because we're seeing more patients in less amount of time. It's becoming, get them in, get them out, see as many patients as we can because we don't have enough time slots in the day to see everyone. So these challenges, as you might imagine, are leading to unsustainability, unfortunately. So to ensure that these services provided by pharmacists can continue, to increase the prevalence of these forms of patient care, and to better incentivize other innovative practice models or to incentivize other private care practices to take on pharmacists, provider status is a fundamental need. I would like to take a moment to read you this quote. This is from one of my colleagues, one of my physician colleagues that I work with at BVMA who could not be here tonight. Dr. David Myers, an interventional cardiologist that I work with, and he asked that I read this on his behalf. As a practicing cardiologist, I find clinical pharmacists to be an indispensable part of the healthcare team. Their unique training positions them perfectly to assist in management of patients with antiarrhythmic medications, diabetes, hyperlipidemia, etc. Reimbursement at a 99211 level is not nearly sufficient to effectively utilize pharmacists in clinical practice in their full capacity. This level may be appropriate for a simple nurse blood pressure check, but inadequately compensates for the complex visits encountered by pharmacists who can spend considerable time in direct patient care in order to determine the best course of action. Clinical pharmacists have been shown in the literature to be far superior to non-pharmacists, including physicians, at managing warfarin, a medication with dangerous and very costly consequences if not managed appropriately. There are very few clinical pharmacists employed by private practices currently, and this is mostly due to poor reimbursement. Pharmacists should be elevated to mid-level provider status and permitted to bill appropriately, similarly to PAs and nurse practitioners. So that is his letter of support. So in conclusion, it is necessary to promote the growth and role of the pharmacist as a mechanism to improve health care outcomes for our patients in Ohio. Including pharmacists who are the medication experts in the primary healthcare team will increase access, improve outcomes, and demonstrate healthcare savings for Ohioans. And with that, I would like to turn it over to my colleague, Dr. Andrew Vistas, who is a pharmacist as well as has his MBA, and he's a professor of pharmacy practice here at the University of Findlay, and he has vast experience working in the mental health arena. So I'll hand it over to Dr. Vistas.
Thank you, Dr. Surwick. As soon as this goes up. Can you hear me with where it is? I'll just leave it there. Okay, cool. Okay, I'd like to talk to you a little bit about mental health and the impact of pharmacists in that arena. Before I do that, though, I think it's important to talk about mental health in general. If you look at the data, we now have about 1 in 5 adults in the United States that's impacted in some way, living with mental illness. That accounts for about almost 45 million Americans. With that, tell me if these don't advance. No. Then I won't have to keep looking behind me. Of those 45 million, what's interesting is only 19.2 million, or about 43% of them, have actually received mental health treatment in the past year. Similarly, those persons experiencing serious mental illness, that is a mental illness that significantly affects their ability to function in society, to be able to live with family, to be able to hold a job, that accounts for about 10.4 million adults in 18 years of age and older, which is basically 4.2% of the total adult population in the United States. And of those, only 6.7 million, or 65% of those, actually received mental health treatment in the past year. So you can see that in the area of behavioral health and mental health, there's a significant need for addressing the needs of those persons with mental illness. If we look at the number of practitioners that are involved in the treatment of psychiatric patients, the data would suggest that if you look at some of the more medically oriented fields, that physicians going into those fields are tending to grow. Whereas in psychiatry, there's an actual decrease in the number of psychiatrists that are intended to be in practice over the next few years. When you look at how that impacts on the number of patients per physician, it's staggering. Within family practice, we're looking at about 3,000 patients per physician in the United States. In internal medicine, again, about 3,000. In family medicine, about 1,500 patients per physician. And in psychiatry, it's over 8,000 patients per psychiatrist. So again, we can see where the impact of pharmacists being able to provide some service to relieve that burden for those psychiatrists is quite significant. Within the area of psychiatric pharmacy, we're honored to have the privilege of being board certified. And with that, some additional training and experience in being able to provide high-level services for those persons involved with psychiatric disorders. The concept of using pharmacists in the treatment of psychiatric patients it's not new. There is a white paper that's now published from the College of Psychiatric and Neurologic Pharmacists that identifies a number of studies that have shown an impact and the benefit of the use of pharmacists in treating psychiatric patients as a collaborative member of a medical team in treating those patients, whether they be for psychiatric or neurologic disorders. As I said, the concept is not new. If you go back to my day, kind of when there were 2 drugs available, 1978, some research was done in the outpatient setting in community mental health centers, evaluating 3-year data in pharmacists who are specifically trained to address the needs of psychiatric patients. In those, they found the cost of medication monitoring was 40% less than those provided by psychiatrists. And patients were actually functioning as well, if not better, than those being treated by psychiatrists. Similarly, on an inpatient basis, in this study evaluating the activities in a 40-bed psychiatric facility utilizing 3 certified pharmacists versus 2 psychiatrists, while there was no difference in the prescribing and the use of anticholinergic medication, the pharmacists actually did significantly better in providing services for neuroleptics and antidepressant drugs. Similarly, again, with an acute adult psychiatric facility, this evaluating the impact of implementing clinical pharmacy services in that setting, there was a significant reduction in antipsychotic dosages, a faster rate of discharge or transfer to less restrictive environments, and a decrease in the readmission rate over a 1-year follow-up period for those patients that were being followed by psychiatric pharmacists. I was privileged to be able to provide psychiatric services to our local mental health center in Century Health. And as you can see from the slide here, I had a number of different duties. I was counseling patients on their medications, doing drug regimen reviews, doing drug utilization reviews. I was also privileged to have a number of my students be able to perform some services and provide some activities at the center as well. I was advising patients on their individual medications. The service that I provided was more of a collaborative service or consultative service. I did not have a collaborative practice agreement, primarily because a lot of the patients that I served were being served by nurse practitioners. So I could not have a collaborative practice agreement with nurse practitioners. I did have a number of patients who were referred to me by the psychiatrists, as well as the nurse practitioners, but from a collaborative practice agreement point of view, I couldn't do that with the nurse practitioners. So basically my activities were around identifying what was going on with the patients, determining whether they were doing well or not, and then having to consult with the psychiatrist or nurse practitioner and then adjust their medications accordingly, and then I would call them in as a verbal prescription from that practitioner. While I was at the mental health center, my activities were basically guided by what was previously the pharmacologic management service that was part of the Department of Health, mental health here in Ohio. And as you can see from this, there were a number of different activities that were specifically outlined for pharmacists to be able to provide. That included addressing their psychiatric health needs, evaluating their medications, informing the patients as well as their family members about their medications, and assisting them in obtaining their medications as well. So a lot of my consultative work was also in working with these pharmacies that the patients were getting their medications at. Similarly, considering their allergies, substance use, current medications, providing health education for the patients and for family members that were coming in with the patients themselves. With the previous code that was available here in Ohio, I was providing, as I said, what were called pharmacologic management services, and the eligible providers for those services are listed on this chart. And I'm not expecting you to see in detail what those are, but you can see there are a number of positions that are listed along the left-hand side. Physicians, nurse practitioners, physician assistants, social workers, psychiatrists, psychologists, counselors, etc. And if you focus in on that, the services that were being provided specifically under those pharmacologic management services included a pharmacist, specifically designated within the code for providing those services in mental health. That included pharmacologic management, and then for those patients with severe mental illness, it also included assertive community treatment for those patients. However, in 2017, there was a revision in the code in the Department of Mental Health. And with that, while they kept the general services associated with that, the concept of pharmacologic management was actually rescinded and removed from the code. Fortunately, within the general services code itself, you can see that the services can be provided by general practitioners within the code. And Appendix A of this new code identifies those persons who are credentialed to provide services within the Department of Mental Health. Those include, obviously, physicians through the Board of Medicine, nurses in the Board of Nursing, and also pharmacists within the Board of Pharmacy. But you can see that the description of what was able to be provided is significantly less prescriptive than what we saw in the previous code. So with that, we have medication prescribing, medication administration, and medication monitoring. So my take of the new code is that we kind of fit in with the medication administering and monitoring. What's interesting, though, when you look at the credentialed providers, pharmacists are the 27th on the list. And it almost appears that they were kind of an afterthought and put into the code, possibly upon reminding someone that, hey, hang on, what happened to the pharmacist that used to be in the code? What's interesting is if you look in the Veterans Administration system in the VA hospitals, pharmacists have a significant role in the VA hospitals. And my hope over time is that we can provide a similar kind of service in the general public outside of the VA system. Here is a study that was conducted in 1993 that describes pharmacists' psychiatric prescribing privileges. And at the end of a 4-year period, pharmacists were seeing 46% of all psychiatric medication visits. That's probably, I don't have the numbers currently, but I have a number of colleagues who are in the VA system now. And the clinical pharmacists are actually running the psychiatric clinics under the auspices of a protocol being overseen by the psychiatrists that they're working with. And if you look at the current positions that are being advertised within the VA hospitals, you can see here the persons are functioning, as they say, at the highest level of clinical practice, working independently, serving as a mid-level provider, functioning to initiate, modify, or discontinue medication. And this person will serve as a provider with prescribing privileges as outlined in the individual scope of practice. So again, I'm not suggesting that pharmacists should have prescribing privileges, but as Dr. Snyder indicated, we do have the ability to do that within a collaborative practice agreement currently. Similarly, in Missouri, Kelly Gable is one of the more progressive persons within the CPNP, and you can see here that she has significant accolades from the Missouri Department of Mental Health and their decision to authorize pharmacists as authorized providers in the treatment of patients with mental illness. And I love this quote. There's no way we could get our clients the kind of close psychiatric attention, medical attention that they would need without her. No way. So with that, what's interesting is if you look again at the white paper provided by CPNP, it closes with the concept of being able to get reimbursement or being able to bill for your services. So with that, there are currently very limited mechanisms for compensation. Hopefully with this new bill, we'll be able to impact that significantly and be able to get back on the road to providing those services for the patients. And with that, I would hope that we would then be able to become not just practitioners and consultants, but certainly psychiatric pharmacist providers. And with that, I would like to bring up Dr. Tanya Dodderman. Dr. Dodderman is Assistant Professor of Pharmacy Practice and the Chair of the Experiential Education Department at the College of Pharmacy. She's also an ambulatory care pharmacist at Lyon Memorial Hospital and a certified diabetes educator.
Thank you, Dr. Vistas. So my job is to talk about the money. I think we can stop now and carry on to the next one. No, I'm just kidding. There's not a whole lot to talk about because we don't have a lot of reimbursement services and methods for reimbursement. But I'm going to talk about the potential for that. But we need to kind of review here, why should pharmacists be recognized as providers? As my colleagues had mentioned that it's going to improve access to patients that need it, especially in the areas where they may be lacking certain providers, such as cardiologist or endocrinologist. That is one reason. Maybe it's an underserved area. So improving that access for care in the growing population and as an extender of to those physicians. We always say, let's improve outcomes, but what does that mean for the patients? It's really improving their overall health care. If we can improve their overall health care and have better outcomes for them and things that they can realize, whether they're humanistic or their clinical outcomes, they're going to be happy with the services that we provide. The insurance companies will be happy because we keep them out of the hospital. That's a huge benefit. And lastly, it would also be saving cost. And so there's been the MTM project. We mentioned earlier, there's been a 1 to 4. So every dollar that was spent on pharmacy services, we recognize there's approximately a $4 savings. So with that being said, it would be about a 300% savings. But we need to find a way to have a sustainable model. We have a lot of these research and practice and dollars that were given on scholarship towards this or grant dollars, but we need to make this model more sustainable. Kind of back to our story just a little bit more, back in 2012, the Surgeon General, now this would be more from the federal standpoint, but the Surgeon General made a statement saying and identifying pharmacists as a means for healthcare reform, delivering, expanding those patient care services. And perhaps it was because of that VA model that they were exposed to and recognizing the advantages of having pharmacists deliver those services and actually writing a letter of support for pharmacists, which was huge. That may have led to some things we'll talk about here in a few slides, but just to kind of go over in a quick review, Medicare is federal, Medicaid is state, and then we have that commercial insurance, and that's various out there. Within those, we found little ways to be able to provide some services, but it's certainly not without a little bit of hoop jumping. So just when you think you got this cool practice that you want to deliver, you say, the hoop jumping turned out to be a little bit more than we thought. So that kind of gets us caught up in moving forward and having a sustainable model. Under the federal health care programs, there's Medicare. Medicare is for the elderly. Medicare Part A is for inpatient services, and that's not really what we're going after right this moment. That's not what the Senate Bill 265 or even the federal, but then there's also Part B. Those are the outpatient services. Those are those physician offices that we collaborate with and we want to be able to bill for our services under those practitioners. And then there's also Medicare Part D, which is something tiny bit more sustainable, which maybe many of you are already familiar with under Medicare Part D. It's the federal government that has partnered with plan sponsors and allow for Medicare prescription coverage. So yes, it's a dispensing component, but alongside of that, they've also have a consulting component to that, where we think of our MTM, medication therapy management, and those CMRs, comprehensive reviews. So there is a way to get some reimbursement through that, and we think more of that in that dispensing model. But Medicare said, if I'm going to spend money on all these drugs, we want to make sure that we're doing a good job with those dollars that are being spent on those prescription drugs for the elderly. So they came up with this Medicare Part D part with the MTM, and they said, we want to make sure that these plans are covering drugs and optimizing therapy. We want to make sure that these elderlies are not at risk for adverse events or minimize those. We want to make sure that you're cooperating with, physicians, that there's some communication going on, which there is when pharmacists are doing MTM services. And that these services must be provided by a pharmacist or another qualified individuals, which is not really outlined to the extent that we'd like to see that. But just to give you a little bit more background about Medicare eligibility criteria, which is kind of a model moving forward. So we use this as a template, is why I'm introducing this. There's different types of contracts out there in MTM, and I'm not going to go over those specifics. But if you look at probably the majority of them would like patients to have 3 chronic diseases. A few of the contracts, we'll say in the blue, will allow them to have 2 diseases. So anywhere from 15 to 20%, around 80 to 85% for 3 disease states. Why is that important? And again, it's if somebody's going to pay for your services, we want to make sure that there's a need. And we identified that the need becomes when there's 2 to 3 disease states. So we're not targeting a patient who's just getting a one-time medication necessarily. Our dispensing pharmacists can help with that and do that basic consultation. But these are the more complex patients, and that's what we're targeting, those patients that have a bigger need. And what do those disease states look like? Just what you might expect. There's diabetes, heart failure, dyslipidemia, COPD, hypertension, asthma, osteoporosis, depression, arthritis, and other cardiovascular disorders. Not surprising there, but those are the areas that we can target and make a big difference on. If we do look at those MTM codes, which we can bill for, there are 99605, 606, 607, which is very interesting because right now, from what I have learned, is that it's a flat rate. Whether you spend the first 15 minutes with the patient and you spend another 15 minutes with the patient, you pretty much get a flat rate once you've done the comprehensive review. They range from $70 to $80 if it's face-to-face. There may be a little less, a little more, but this is just an estimated average. But that's what we get reimbursed. And those can take an hour to an hour and 15 minutes. Sometimes we have our technicians or somebody else helping with that process. So it's pretty much a break-even type rate for those services. And again, that's the face-to-face. We have an MTM center here, and that is more of a telephonic. On some cases, we do video chats with the patients, of course, HIPAA compliant. But it's not to this level of reimbursement at all times. There are other models being tested out there through CMS because they recognize the benefit. The federal government recognizes the benefits. So they are looking at more disease state management, MTM built within physician offices and academic healthcare centers. So they are open to that. They just need to have the data and the proof. The state program, which we know is Medicaid, not necessarily targeting it on this bill, but I just wanted to kind of touch on this, does cover prescription drugs. Medicaid currently does that. For some long-term patients, depending on their diagnosis, they'll cover some over-the-counter meds. They'll cover influenza vaccines and the rates, administration rate there. But no routine billing right now for MTM as a direct payment. Maybe through a plan sponsor or something of a different nature, but right now not directly. So we're missing out on some of those Medicaid patients that we might be able to help. However, we also have the health insurance plans. That's your Blue Cross, Aetna, Blue Shield, etc. And they typically model their payment after Medicare or Medicaid. Good, bad, or different, but that's how they model their billing codes. And the other thing that a group can do, they can say, for example, a company can say, I would like to have diabetes services covered. I recognize that I have a bunch of patients or a bunch of employees that have diabetes and they are missing a lot of work. So a company could actually contract or reach out to their healthcare insurance plan and say, I want this service covered. That would be a perfect world for us. And say we need education in this. And then we could get reimbursed for those services as long as we're still working within our scope of practice. But most insurance companies are not out there really necessarily advocating for that for us. And I'm not sure that employer groups actually know some of the things that we can actually do for them and their employees. To give a little bit of background, there's the Health Collaborative Practice Bill 188. This was a bill that was back in 2016, I believe. It reduces basically the paperwork involved with physician offices and pharmacists collaborating together. So the models that Dr. Sur was explaining, the model that I could be using at Weimar Memorial, we can collaborate with a physician. Now, I currently work in tandem with a nurse practitioner, but I'm not collaborating, and that's not what it is. It's more consultative again. But in that scenario, we have reduced paperwork. We can now order some blood work and urine test if it's written into our collaborative agreement. We can actually analyze those test results, and within our agreement, we can actually modify drug regimen therapy. So if you want to say that we can prescribe, perhaps, but it all has to be laid out very clearly in that collaborative agreement between us and that physician. So as long as we're working in that model, we have that potential. So right now, the way we get reimbursed in those physician offices are primarily what's called a 99211 number, and it's that face-to-face management with minor problems. Anywhere from $10 to $19 is what we get reimbursed. That's the Medicare range that they had listed. Again, that's really tricky to be sustainable. There are other levels of service, not to inundate you with a bunch of numbers, but the reimbursement amount goes up based upon the minutes that you spend and the types of services that you provide while you're under each one of those codes. Right now, pharmacists cannot bill on their own. We don't have the ability to be credentialed, and we can't use our NPI number. So our NPI, National Provider Identifier number, is what insurance companies read. And again, we're not really able to bill under that for ourselves. So to use Dr. Surwick's model a little bit more, pharmacists work in the anti-coag clinic. Sometimes they're actually set up for 6 to 8 patients an hour, knowing that some won't show up and they're going to see 4 to 5, but they're actually scheduled up to 6 to 8 patients in an hour to break even, knowing that some won't show up. And they're only billing under that 99211 code. And as she mentioned, if you end up getting a patient with a more complex problem and you need to spend a half an hour going through their meds and checking what drugs they're actually on and looking all this stuff up for them, now we have backed up our entire patient afternoon. So we just have to be really careful and be advocating for ourselves to have a little bit more time for our patients and being reimbursed at a higher rate. The other tricky part to this, I don't know that it was mentioned, if a physician had already seen a patient that day, we're not able to bill for that patient. So in the instance, if that patient came in under that larger group, that BVMA group, or if they were seeing Dr. Meyer that day for maybe checking their pacemaker, but yet they still had an appointment for their Coumadin or warfarin, Dr. Sorwick's not able to bill that day. So there were two different things, but she would not be able to bill for that service that she provided. And that's really a disservice to our patients, because you got an elderly patient who maybe is getting transportation and nobody else can bring them in, but this day they've got their appointment set up and now there's no reimbursement for that extra service. Yeah, you could say, come back tomorrow. Well, that's really a disservice to that elderly patient to say, come back tomorrow and we'll take care of it because we'll get paid $19. That costs more than that probably for gas for them to get there. So depends on what your clinic's roles are, but it would be nice to be able to treat them fairly and take care of them when they walk through the door. So that can be kind of a tricky thing for them patients, for those patients as well. That's just kind of what I went over. Reimbursement services are based upon what's called a healthcare common procedure coding system. This is something we would be marching forward if we got provider status. We would be able to use those codes. These are the codes that the physician level is used now. So level 1, category 1 is called an incident 2. codes 99211, and then they progress. There's also, under these CPT codes, something called a G code. And these are temporary procedures and professional service codes. These can be used for many things, but one example would be PT and OT services. So under this current model, they can bill for their services and be recognized with their NPI number, but pharmacists are not right now on their own. Chronic care management is other codes that are out there. This again is some hoop jumping, and they are changing the game. I just learned last week at my practice site, since I turned these slides in, that it's a little bit tricky based upon what model they're signed up for. So even though there's chronic management codes out there that can be utilized, again, not under the NPI numbers, but if we collaborate with a physician, we could use their NPI number and get reimbursed under these services. Just another model to hoop to jump through if you're interested in setting something up. Diabetes education, I had a rude awakening. I went to go get my CDE. I was all excited, and I said, that's one way I can make this happen, one way I can get reimbursed being a diabetic educator. But I learned something, of course. Even though there's 100 million people out there needing diabetes services or pre-diabetes, and I said, great, if I become an educator, that I can bill for individual education under one of these two codes. And then I realized that I can't bill under my NPI. I'm like, well, that went down the tubes. So I had to go partner with a physician again or a dietitian. But obviously we want to partner with that physicians or MDs so that we can maximize the collaborative practice component of that. So that was a little bit of a disappointment. The other way pharmacists bill, again, this is not perfect worlds, but this is ways models are trying to be tested and tried, is through an annual wellness visit. Again, it's through that physician NPI number, but these are a way that we can do some assessments on these patients. As you can see, they will allow nurse practitioners and PAs to do this, but if it's under a pharmacist, we have to bill under that physician component. And if that patient comes in for their annual wellness visit and then they say, I haven't been feeling really well, I think my blood pressure's up, and they go over and see the physician for the day, then that precedes this code, and then again, we're kind of out of our services being reimbursed from what we did. If we spend an hour with this patient on their annual wellness visit and risk assessment piece. So by allowing pharmacists to have provider status, kind of summarizing, we will have, improved access for the patients out there. When they need somebody, we will be there, and we can hopefully manage their medications and avoid them being admitted to the hospital. We're offering educational support, especially in diabetes management or heart failure management or asthma management. We're improving overall outcomes to those patients' health, lessening their needs for transportations, and again, that kind of going back to access, and then overall, reducing overall healthcare costs. There's many literature reviews supporting the fact that when you involve a pharmacist, especially in these chronic care management situations, that the overall healthcare goes down. We have less admissions, less adverse drug events. I don't have the site memorized, but I know I mentioned to many of you guys in class about back in 2006, there was $76 billion spent on adverse medication events, morbidity, and mortality. $76 billion. That study was reevaluated, the sources in the nation, and in 2016 it was over $200 billion spent on adverse drug events, morbidity, and mortality related. So when they say it is going to be costly to have a pharmacist involved, we're already doing some things, but we just have to jump through a ton of hoops to do these things. Again, taking away from patient care. But overall, we can make a positive impact, and the data is out there. And there's money to be had because we're spending it on the adverse events, but we don't want to have to spend the money on that. We'd rather spend it preventative, and that's really what we're looking at from our perspective. So with that being said, we do have a patient advocate coming in, but she is not quite here yet. Oh, okay. I will let Dr. Serwick introduce our patient advocate, and that concludes my part. So.
All right, so I am pleased to announce Mara Drace. She'll be coming up here in just a minute. I wanted to give a little introduction to her. So I saw her dad, Robert, for many, many weeks, I would say pretty much weekly, back in 2014, 2015. She'll be able to give a little bit more in terms of dates. But I was seeing her dad for heart failure management at BVMA when I was a resident, and then into when I was transitioning and not a resident anymore. And we built a very great relationship, a very close relationship. I saw them, like I said, every week, and we did lots of drug therapy changes in management to try to keep him, as comfortable as possible and keep fluid down. So she is here to just talk a little bit about her dad, a little bit about what we did in the clinic, and she has some good stories to share with you. So, Mara?
Hello, everyone. Thank you, Susie. And as my dad would have said, it's Bob. My dad passed away nearly 3 years ago, and I was really surprised to get the call from Susie to come and speak with you this evening, and I'm really pleased to do that. My dad benefited greatly from what pharmacy had to offer him, his positions at BVMA, Sarah Hirschman, who is what was that called? Care Navigator. Everybody really worked together as a team, and it was hugely helpful to my dad. My dad's health problems started with a heart attack back in 1976, and he had not like the first bypass surgery, but one of the first bypass surgeries in 1978. And he developed just a lot of health problems. And when I went in to be with him in one of his appointments after my mother had passed away, I noticed the size of the file. It was still a paper file. It was about this thick. And they said, well, that's one of 4. So I'm sure even after that time, it got bigger on the electronic record. So everybody really wanted to help my dad because, as they said, whatever we asked him to do, he would do it, and he would have a chart. And my dad had about 4 strokes, and so he couldn't function as well as he used to at one time, but he was strong in a lot of ways, and he didn't give up. There were times when he wanted to, there were times when I wanted to, there were probably times when his healthcare team wanted to, and anyway, we kept him out of the hospital more often than not, even though he was a frequent flyer at BVMA. So my dad had a pacemaker put in, I believe, in 2011. I could be wrong about that. I just, this past summer, shredded the, all the paperwork that I kept. I kept a folder, and I did a lot of follow-up and coordination with the healthcare team. So anyway, I don't remember all the details, but I think it was 2011, and it had the capacity to, where they could hook up the Optival device and check his fluid levels. And I don't know if that's how it's done everywhere, but anyway, Susie was just an enormous help in that because we coordinated with Dr. Meyer, his cardiologist, and with Dr. Aboya, his nephrologist, and that was critical information. And my dad would weigh himself every morning, and we recorded it, and if anything would get a little bit off, because anything would tip him over the edge, because he also had congestive heart failure. He probably weighed just a little over 100 pounds when he died. But so anyway, we would adjust. I'm saying we, because we all sort of did it together. We'd have long appointments there at BVMA, and Susie was right in there pitching. She had this huge role in facilitating things with Dr. Meyer, because Dr. Meyer could only see him, I don't know how often, but it was like months, several weeks at a time, and Susie could see him every 1 to 2 weeks, I think it was, and they drew labs, and we just had a lot of follow-up. So there was the Bumex and the spironolactone, and they tried Lasix again for a little while, and that didn't help. And But just any little thing could tip him over the edge, and they were there ready to do whatever needed to be done. So I guess I was my dad's advocate. I just saw myself as a daughter, but if I could be of any help in advocating for you as pharmacists to get the kind of compensation that you should be getting, I would be happy to do that. And Susie did ask me to share, I asked if I could share another story when Dad was in the hospital in Toledo, because this was before we got this team effort together on really following up on his medication. I also moved back to Findlay to help do that when Dad just wasn't able to do it by himself anymore. But before that, there was some confusion about what his dosage of one of those diuretics was supposed to be. And so he ended up falling in the middle of the night, bumped his head, not real hard, but bumped his head on the chest of drawers, and there was a small brain bleed. So they, took him up to Toledo, and they had, of course, no information up there. Kind of forget where I was going with that, I'm sorry. The pharmacy students, thank you, yes. They were interns up there. And because they had no information, they weren't sure what had caused my dad's fall, even though I shared a lot of information with them. So they were giving him a lot of different medications. One of them was appropriate because of the small brain bleed, I guess, but it was Keppra. And one of the pharmacy interns came by when I happened to be there in his room and shared with me the side effects for that drug. And I said, that's exactly what's happening. And they were even trying to do like a heart catheterization, which we had to stop right away because that would have tanked his kidneys, and it was a lot of drama. And when they say stat up there, they really do mean that. They all came with the wheels and then stopped, and it was kind of humorous when it was all over. But anyway, the pharmacy intern shared what the symptoms were of that Keppra, and so I was able to advocate for my dad, I guess, in talking with the doctor, and they didn't want to reduce the dosage of that, but when they did, he just snapped out of, what looked almost like a semi-comatose state, and he was fine. He was walking the halls. My dad rallied a lot in his medical history. So another thing was they thought maybe there was some sort of an infection, so they were giving him something to swish his mouth with. I don't remember what that was called, but another pharmacy intern said, you might want to talk to them about this if there's really no danger of infection, because it can make his teeth turn brown. So we stopped that, and Dad's teeth did turn a little bit brown, but maybe they didn't turn as brown because of that. So those were just some examples that I remember of how pharmacy interns were and pharmacists were very, very helpful in my dad's care. So, anything else? Thank you.
All right. Thank you very much. That was a wonderful, wonderful discussion that you were able to provide. It is my pleasure now to introduce the Executive Director of the Ohio Pharmacists Association, Ernie Boyd. Ernie, I'll turn it over to you.
I really appreciate the time here. Mara, if I may call you Mara, thank you so much for speaking and adding the idea of what we're really about is here to represent patients and to serve those patients. But if we're not able to be employed in that activity, they can't get what they need, right? And it was so great for me to hear other speakers talking about the economics of pharmacy, because many times I'm kind of seen as the one who's pounding money home, but at the end of the day, hospitals open and close based on one thing, income, right? And the same way with pharmacy as part of that system, we need to be there. in my slides, I'm going to be talking about, need to make sure I do this correctly. Yes. Some of the political ramifications that you need to think about with this provider status bill. On the federal side, there are some barriers out there. CBO, the Congressional Budget Office, takes a look at what is the cost of this. Now, the problem with CBO is they don't look at the other side. Remember that slide you saw that they save $4 in costs for every $1 they spend on you? Well, the $4 doesn't show up in the equation. So CBO says if we add pharmacists, it's going to be millions and millions of dollars. And so when we work with these congressmen to get this bill passed, and right now there are almost 300 that are in the House bill, there's a lot of support. We also have to overcome the problem of the cost and talk about what is this going to save the country and save patients. And the number you can feel comfortable using is for every dollar they pay us, we'll be saving the whole system $3. And that's very important because to overcome some of these things, you really have to be careful in how you explain it. On a state level, we don't have the same problem there. As a matter of fact, we have been working on this legislation for quite a while. We have quite a few folks in support of Senator Dolan's bill. And the situation on any state legislation is we need you to first know who your legislator is and communicate. Now, if I were to give you a little quiz and your graduation were dependent upon passing, and you have to name 5 names, let's see if you could do it. Who's your state representative that votes in Columbus? Or if you're from another state, your state capital. Who's your state senator? Can you write their name? Do you know who they are? Who is your congressman? The person that's your representative in Congress, and that depends obviously on where you live. But who are Ohio's 2 senators in Congress? Anybody? Last name. I'm sorry? Portman and Brown. Excellent. Now, I expect you to know those 5 names because the rest of this is all theory. If you aren't taking action and writing a note on these, and I know these magic boxes are going to be filled to the brim with your letters to about these bills, we can make an impact, and that really is the key. The barriers to the state legislation are not many. We have one that you might think is impossible, and in some years it is, and that's the state insurers, the health plans. But we've cut a deal with them, and we don't think they're going to oppose it. Physicians normally oppose this kind of thing. Seeing another provider group come out, we have worked behind the scenes with them for over a year, and it's becoming clear that we don't know if they'll support, but at least we don't believe they're going to work to kill it. But here's the real trick to getting legislation passed. You are privileged to have in this audience John Cross, who's running as state representative for the 83rd District. And why do I say that? Because very few times do Antonio and Michelle and I have an opportunity to have this much time with people much smarter than me giving legislator presentations on the provider status. When you give your presentation, you'll probably get about 5 minutes to your legislator. Make sure that you're clear. Make sure you have a story. Okay, you heard a story from a patient here. But story is important. If all you give are facts, you won't sell your case. I guarantee it. You have to talk about how you could did directly impact a patient, or if you're not yet to that point, you need to talk about a case that you think could be reasonable and talk about how you could intervene. Let me give you an example out of the mental health world. When those regs changed, we had a problem with Medicaid. Up until December 31st, pharmacists were being paid under our new legislation allowing you to administer long-acting medications. There's a group of about 7 pharmacists administering long-acting mental health drugs. Medicaid changed their payment scheme in December and cut off all those pharmacists, saying they're not providers, we're not paying them anymore. So those patients lost access, and what's one of the number one reasons patients have relapses in mental health? They don't have access to the medications, right? And so it is absolutely critical that we utilize stories such as that to get this through. And then if you get a real story of a real patient, for instance, we've been fighting to make sure all pharmacies have access to insurance contracts. And you say, well, do I really care about that? Well, you do care if you live in a place like my wife's pharmacy in South Charleston, and a lady from a little town called South Solon changed her insurance, and the pharmacy benefit manager said, must do mail. Well, my wife delivered to her house in South Solon. There is no mail delivery in South Solon. You have to go to the post office. She is disabled and has no family, has no transportation, and you can't get a cab in South Solon, Ohio. And so she wrote a 3-page letter to an insurance company. She carboned me and my wife, trying to get my wife's pharmacy put back in the network, and they wrote back, no, you must get your drugs through the mail. Those are the kinds of stories that help people like John Cross understand the flesh and blood of these issues. And on provider status, what we'll be able to do is help all these folks who are baby boomers like me, who are now needing care, and there are not enough physicians, true? There are not enough nurse practitioners to care for them. You folks are very well trained in so many different areas of medication and of medication use that you're going to be of great help. How do you get support? You need to contact these people. That sounds just so, yeah, I know that. But so many pharmacists don't do that. Same thing with health professionals generally. Many of them complain about an issue, but you say, well, hey, did you contact Senator Brown, Senator whoever? And the answer is, no, I haven't had time. You need to take time, because if you don't give the story to these folks, it's a problem. Second part, keep it simple. You've heard the discussion here. I always tell my lobbyists, both Michelle and Antonio, if we can't tell our story one page, one side, we're dead. You've got to get your elevator speech in your mind on even complex issues. They will not accept and shouldn't 20-page document detailing everything about whatever your problem is. Same with provider status. You may want them to, they're not going to read it. So don't waste your time. And when you come testify for us, which some of you will, I need you to cut to the chase and talk about the high-level things and make it as simple as possible. Why? Because they're simple people? No, because they're not healthcare providers. When I take folks up on the Hill in Congress, and sometimes pharmacists will get real frustrated and they'll look at me and say, well, they didn't even know what a PBM was. Well, that's 3 letters you use and they don't. True? Can you think of any words in pharmacy that you use and humans don't? Okay? And I'm going to push you just a little further. If you really want to influence John Cross and other legislators, how many times have you seen anything about a pharmacist in your local newspaper? How many publications do you have personally, including letters to the editor? Name them all. Is the only time the pharmacist gets in the paper if they steal the drugs? True? Now we've been blessed in Columbus, we've had 57 front page, above the fold, front page stories in the Dispatch on the problems of PBMs. And yes, we did light that fire. However, why is it that the engineering school in Columbus gets a picture of a fine little car that has a satellite on top of it and runs across the desert every year, full color picture? College of Engineering, hey, we're doing great stuff. How many of those have we had in pharmacy in any city? Not many. I challenge you, and as students, I know if you do a rotation in my shop Amy has you at least get a letter to the editor published. Say, well, that's not a big deal. Yes, it is. Because you know what? People who are old enough they still read papers, read the letters to the editor. Get on a radio show, talk about pharmacy. I still have my wife had a patient come in and ask, Twyla, how long would I have to work behind the counter before I'd be a pharmacist with you? He thought it was an apprenticeship program. Okay? Now, we can kind of giggle about that, but sadly, John, a couple of years ago, I had a legislator come up to me and say, do you go to college to be a pharmacist? It's not because he's not bright. You know what the problem is? We're not in the newspaper, in a good way, saying it takes 6 years to be you've got to publish in things that humans read. We really need your help on that. You know, there's a lot of things about what we talked about tonight that are very specific. Obviously, none of mine is specific. But I want you to understand that it does matter who you know. Tonight, you'll have an opportunity, hopefully, to stop by and say hello to John, who's running for the state legislature. And I kind of warned him about this. I was going to see if he'd mind coming up here and taking a couple minutes of my presentation and talk about what this might have meant to you and anything else that you might want to add. So, John, please welcome John Cross, running for state rep.
Good evening. Nothing like being put on the spot. I actually asked this, can I get 15 seconds? I don't have any prepared remarks, but I just wanted to talk to first the faculty and the staff. Dean, thank you very much. To the faculty and staff, this was extremely helpful. Not knowing too much, obviously, about Senate Bill 265, I gained a great insight tonight. And so these kinds of events are very helpful because, just for everyone in the room, my background is in economic development. I serve as the economic development director and the CEO of our chamber in Hardin County in a small town called Kenton, Ohio. And we're very blessed to have Ohio Northern University and a good pharmacy school there as well. I've also have a brother-in-law who's worked at the VA, as a pharmacist. My wife's aunt and uncle are both pharmacists. My father-in-law is one of the top neurologists in the West Coast of the United States. His father was a doctor who's worked out of his house in Hoboken, New Jersey. So for me, having family discussions, I've learned history and how doctors treat patients and how things change and evolve over time. And now, as a potential legislator after November, this to me is a very common sense thing. Healthcare is changing, and sometimes we don't have a lot of common sense and decisions. But tonight, for me, this person has to not only count pills but count votes. And so when you're trying to pass legislation, you got to know where legislators stand. Well, tonight, this is a no-brainer. And so I hope if this legislation gets moved through to the House when I'm down there in Columbus in January, we hope to be a good advocate. This makes sense. Listen, for all of you youngsters in the room who are working towards that white jacket, there's a lot of smiling faces and a lot of energy. Your time is valuable. And as a patient, as a consumer, sometimes we don't take advantage of you all and what you do. And particularly, when I have to go to CVS or Walmart and talk to a pharmacist, I'm always asking them questions about stuff that's over-the-counter drugs. And so gaining your insight and your knowledge into medicine is very important, just as important as talking to doctors. So to you all who are working towards your white jackets, thank you very much. Let me add this. When we talk about the drug epidemic here in Ohio, there is not a perfect solution to the drug problem. I remember in third grade, my DARE officer, Ron Rogers, I remember Nancy Reagan pushed a Just Say No campaign, and we're missing some of that national unified voice when it comes to the drug issue. And I hope the faculty doesn't mind if I say this, and hopefully it doesn't go against your mission, but you all have an important part to play in helping prevent the drug issue, the drug epidemic that is happening today. You all can mentor young children who are going to look up to you. You are young, you have a lot of energy, you can have a great impact. So I encourage not only our church groups, our youth groups, our nonprofits, but I'm encouraging you all in any way possible, whether it's helping to mentor one child, because what we can't afford is 30 more years of people getting hooked on drugs. It's going to bankrupt our state. And you all have an important part to play in the drug prevention effort that's undergoing. So there's no magic path, there's no correct way of doing it, but you certainly can have an important part to play in mentoring young kids who are going to look up to you. It would be an honor to serve you all. How many of you plan to stay and work in Ohio? Is it, and this is where I don't know, but do you have to have an Ohio license to work in Ohio, another license to work in the state? So everyone's going to work in Ohio here? Good. We need you to be in the Buckeye State. We need you to invest here. We need you to love to live here, work here, and prosper here, because we're losing a lot of people out of Ohio. So thank you for staying committed to this profession. Thank you for staying committed to living and working and prospering in Ohio. I wish you all the best of luck. Now let me double down the efforts. Everybody take out your phone. I know you all have phones. I can't underestimate how important it is to be involved in organizations and the Pharmacy Association, because they have an important part to play. But I'm going to give you all my cell phone number tonight, okay? I've given my cell phone out to over 5,000 people. I've put my career on hold to be a public servant. And I believe the best way to be a public servant is to be connected to the community. So to the faculty and the staff and the students here tonight, that cell number of mine is area code 567-674-7076. 567-674-7076. The best way to stay connected is to be connected. Whether it's a text message on an issue, a phone call, I encourage you all to stay connected so we can make the best business decision. What I ask of all of you is give me the best information so I can make the best business decision and the best common sense decision. And tonight, this is a pretty good, compelling evidence of what needs to happen so you all can prosper and thrive in your business. I appreciate you all. Thank you for letting me say hi tonight, and I appreciate your time. Thank you very much.
Thank you, John.
I really appreciate John taking a minute, and I'll finish with this. Make sure that you do develop your story on whatever the issue is. If you care about it, you have a story. The last thing I'll say on the whole issue of reimbursement for services, make sure that you're also focused on reimbursement for product. John, you mentioned the opioid crisis, and pharmacists are trying to stock a drug called Vivitrol. What Medicaid did to us last year was their PBMs paid our pharmacies $100 per prescription under wholesale cost. We had a pharmacy that almost went bankrupt off that one drug. So we do need to pay attention to the realities of business as well as our health profession. Thank you very much.
Thank you, Ernie, and thank you, John, for sharing your message, and best of luck to you in the final countdown with the election. So with that, I'm going to invite our speakers to come up, and we're going to have a few question and answer panel discussion here. I have a few prepared questions to ask the panel, and then we'll turn it over to any questions that you may have in the audience. When it comes time for audience questions, we do have a microphone, so please raise your hand, and we'll be sure to get those questions asked. So, all right. So the first question that I have prepared, I'll ask Dr. Surwick. Can you talk a little bit more about the 99211 billing codes that you are able to submit in your practice, and talk a little bit about how if Senate Bill 265 is passed, that might change how you are able to bill in that practice?
Sure. So right now, we bill a 99211 for every patient we see, whether that's a quick INR check for warfarin, whether that's a complex hypertension patient, dyslipidemia patient, just overall polypharmacy medication review. No matter what it is, no matter how much time it takes, it's a 99211 irregardless. As far as I know, the reimbursement level for that for pharmacists is $18. So that's why we have to see at least 4, if not 6 or 8 patients an hour to try to just cover the cost of our salary, our benefits, being in the building, the supplies that we use, paper, etc. If Senate Bill 265 would be passed, we would theoretically be able to bill a higher level. So not a level 1 99211, it could potentially be a 99212 or 99213, depending on how complex the medication regimen is, how much time we spend with the patient, what all is done, whether it's a physical exam or what other triage that might need done. We would be able to bill that higher level, and Dr. Dodderman showed some of those reimbursement rates. The higher level you go, the more reimbursement we would get.
Thank you. Dr. Vistas, you talked a lot about the care of psychiatric patients. What do you see as the most important change that could take place to support psychiatric patients?
Well, we've spent a lot of time talking about Ohio, which is fabulous, and I think that's a critical area that we need to address as well. One of the challenges that we do have in psychiatry and mental health is that most of our patients are indigent. They cannot afford their medicines. Not a lot of them work. They don't have insurance plans. So I think in addition to the great work that we're going to do here and the support that you all will be providing to support Bill 265 here in Ohio, again, I would highly suggest and ask that you do contact your national representatives, so your senators and congressmen in Washington, so that they can better understand the needs of those persons afflicted with mental illness and help pharmacists become providers at a national level as well.
Thank you. Dr. Dodderman, you also spoke about several billing codes. One in particular that you mentioned was 99605. Can you talk about that a little bit more? Unless I'm putting you on the spot with that one, but have you ever billed for 99605 in an outpatient setting?
Not really. We cannot bill for 99605 in an outpatient setting, primarily because the hospital or the clinic that you're with would have to have a contract specifically with that plan sponsor under Part D. So unless you're recognized as a pharmacy, like what we think of traditionally as in dispensing, it's almost impossible. I'm sure there's hoops that you can jump through to make it happen, but it becomes very difficult to be able to bill that MTM code unless that plan sponsor has been embedded into the outpatient services, which is something most medical office managers are not familiar with how to get that done because you're not a dispensing pharmacy. So that's where that disconnect is between your traditional Aetna and how they contract with a pharmacy for those billing services versus that Medicare Part D component. So it becomes very tricky.
Thank you. If I could ask a question of our patient advocate. You did a tremendous job speaking about the impact of a pharmacist in the care of your father. I'm interested to get your take as to what that might have been, how might that have looked pharmacist was not involved. How different do you think the care would have been?
In preparing to come here and speak tonight, I looked through calendars that we had recorded all of Dad's appointments on to try to keep up with them because there were many. And the ones with his doctors were few and far between because they can only have so many appointments with a doctor. But, there was lab there several times, and there was Susie, pharmacy, on the calendar several times. So it would have meant, and those appointments couldn't come soon enough, We're like, just get to the next day. It was that touch and go sometimes with my dad. Even though he was out walking around and grocery shopping and everything, he at any time he could fall. So not fall down, but his condition could fall. So I think we just wouldn't have had that kind of close connection and the thought that we could reach out to someone and that they could respond to us and make a difference even if it's tweaking the medication or something. We just wouldn't have had that without pharmacy. And I guess I wasn't really here to advocate for BVMA, but I think Blanchard Valley Medical Associates, I understand, probably took on some costs themselves just to allow for some of those services to be there for, the care navigator and for Susie in pharmacy and so forth, because they really work closely with my dad. So.
Great, thank you. And one final question that I have prepared this evening, I'll direct towards you, Ernie. What can pharmacists, or in this case, we have many pharmacy students in the audience, what can they do to make a difference or to help advocate for provider status?
The number one thing is personal contact. So any of you tonight who vote in Logan, Hancock, and Hardin counties have someone before you who's running for the legislature, and hopefully you'll take a couple minutes and come up and introduce yourself. And I always remind everybody you've got two names, and he'll remember that. It is amazing to me what legislators remember when you introduce yourself. Sherrod Brown, regardless of what side of the political spectrum you're on, has an amazing memory for names. And 2 years after my son met him when we took a group of pharmacists up on Capitol Hill, we're on a phone call, and he says, "Ernie, how's Rich doing at Ohio Northern Pharmacy?" I mean, it just shocks me. And so your short interaction many times makes the difference in whether we pass a bill.
All right, thank you. With that, I would like to open it up to the audience for any potential questions. So if you have a question, please raise your hand, and we'll be around with a microphone. And don't be shy. Do you have any questions, Dean Parker? To get us started? I know. I didn't mean to do that. But
Give me a second.
any others?
I think this may have been implied, but just to draw this out, if I may, Mara. Hospitalizations, do you feel that the involvement of the pharmacist helped avoid hospitalizations for your father?
Yes. Yes, I do think they helped avoid hospitalizations. It was a whole team effort, but without having Susie working so closely with Dr. Meyer and having the ability to check his pacemaker, who measured his level of fluid, we just wouldn't have had the information that we needed, and we wouldn't have had that care coordination that we needed. So yes, he would have been hospitalized a lot more, I'm sure. I think I probably shouldn't speak to this because I don't know for sure, but my understanding was that there were a lot of patients in the hospital who would come in with fluid overload a lot. And my dad, we kept it in a close balance. It would happen sometimes, but we really kept it in a close balance. So with all of his medical conditions, he could have been in the hospital a lot more than he was. Thanks.
Thank you. I have a couple questions over here.
So I don't know if anyone can really answer this question, but I'm going to ask it anyway. So, you have like over 100 sponsors federally, right, for one of the bills that support pharmacist involvement. So it seems like we're getting through to somebody if we have that many, right? So how do we get through to the next level where you've got this finance committee that is like, so are they really that blind to not be able to see this connection here? How do we get past that and convince them that the nation is going to be a lot better off with us providing this service?
So the problem falls not in a legislative committee. It's the Congressional Budget Office, which is an independent outfit that is very tough to influence because they do a good job of maintaining independence. What we need to do is to convince the legislators that it's worth that extra money because the country will save 3 times that in readmissions, et cetera. That's a harder sell, but the CBO number doesn't necessarily kill it. I was personally involved in a bill that had $1 million price tag and was told it was going to die, and we actually got it through Congress with a guy named Charlie Wilson in the House and Sherrod Brown and George Voinovich, and had it signed by President Bush in 3 months. And that was all generated, obviously, out of Ohio, as you can tell by the bill sponsors. But I learned a lot about all that stuff because CBO almost killed our bill. It can be overcome, but it takes pharmacists knowing their case and having a good story.
We have another question up here.
Hi, I'm Jake Lomax. I'm a P5 pharmacy student at Ohio Northern University. Thanks for having us up here. I had a question about the Comprehensive Primary Care Program. It's a payment stream by the Ohio Department of Medicaid. What is your opinion on that, and do you see pharmacists being able to tap into that as a resource?
I think you got me. I'll give you a general answer, but I promise to follow up because there's somebody in that row that will make me anyway. So the deal is that some of these programs you're blocked from all over the place, okay? And what it takes is first identifying what is that source of money. For instance, with chronic disease management, we are cracking some nuts on that. We do have a program in Ohio that is being run through a major insurer where they are now credentialing pharmacists as providers. Okay, now listen to those words. They are credentialing pharmacists as providers because they don't have to have the law changed to do it. And secondly, they're paying pharmacists as specialists at the same rate as physicians, okay? Pilot, 6 pharmacists. But if this works, they are one of the biggest insurers in the country. So please contact me with that particular program. If somebody else doesn't have an answer, I will get it for you, but I don't have the specifics.
Another question?
So I know that there's a lot that has to do with like Medicare, Medicaid fraud, billing incorrectly. What would be in place for pharmacists as providers to be able to make sure we're billing correctly, especially when it comes to not being in the patient's profile, but being directly with the patient? Like, what checks are in place to make sure that we're billing for the proper amount of time?
Okay, I'll try to field this one. So I guess just a little bit of clarity there. So are you talking about if we get to be able to bill a higher level, how would we decide? So I think they'll set up processes just like the physicians have. If you have spend X amount of time with a patient and do X, Y, and Z, then you can bill at this level. You know, I know if Dr. Meyer does a physical exam and medication review and X, Y, and Z, he can bill for a level 3. So it just depends on the complexity of the patient, you know, and how much time you spend with them doing those assessments. So I'm sure it'll be something like the physicians have, that there's, you know, protocols in place for that. So does that answer your question? Okay.
All right. Any final questions? I know we're a little bit over time. Seeing none, I would like to thank the panel for all of your questions and answers. I would like to invite Dean Parker back up for a few closing remarks.
Well, thank you all again for your attention, for your questions. I think everyone leaves this evening having learned a little bit more about provider status for pharmacists, what it means and what the impact can be, not for pharmacists, but for patient outcomes in not just the state of Ohio, as we're focusing on tonight, but for the nation. I want to thank Mr. Cross for taking time out of his busy schedule to be with us this evening and for the positive feedback. I appreciate you saying it's common sense, and we certainly hope that you'll continue to support us when you're in office. Thank you very much to each one of our speakers for being here tonight and for sharing your personal stories. I think that's very impactful, as Ernie said. To hear people's stories makes all the difference. Thank you for those of you who traveled this evening. Safe travels home. Have a lovely evening.